Bismillahirrahmanirrahim. Rabbi zidni ilma. The key to success is to focus on goals, not obstacles. Assalamu alaikum everyone. Under the supervision of Professor Saira Afzal, I am Dr. Sadia Rafiq, and today my topic of presentation is health systems in Pakistan. Learning outline, health system and its building blocks, health system models, health system in Pakistan, mixed health system in Pakistan, including public and market system, health system domains, recent advances, and multiple choice questions. Learning outcome. At the end of this presentation, the participants would be able to describe health systems of Pakistan and its domains. Introduction. Health system. Traditionally, it is defined as comprising all the organizations, institutions, and resources that are devoted to producing health actions. Healthcare system. Part of the health systems delivers personalized curative care or public health services labeled as a healthcare system. WHO describes healthcare system comprising of 6 building blocks. Those are service delivery, health workforce, information, vaccine and technology, financing, leadership and governance. Health system models. Health systems are difficult to categorize into various models due to diversity in financing and service delivery arrangements. Taking finance healthcare as yardstick, health systems fall into 3 broad categories. Number 1 is welfare models. These are predominantly financed through public sources of health financing. Examples include health systems of Western Europe, Gulf, and Canada. Market system. United States of America is the prototype and characterized by market systems of pooling and provision. Third is mixed health system. Majority of low and middle income countries, including Pakistan, fall within this category where publicly financed government health deliveries coexist with privately financed market delivery in health system. Health systems in Pakistan. Health system is much broader than a healthcare system. Factors influencing the health status at individual and population levels can be socioeconomic, environmental, biological, or lifestyle related, and are also relevant to population dynamics, human development, overarching governance, and international and domestic politics. The health systems framework. As you can see, under the governance, there is input. Input includes policies and plans, financing, human resource, infrastructure, medicines and products, technologies, and health information system, which leads to the outcome, which is service capacity and quality, service availability and coverage, and service utilization, which leads to the health outcomes. And these are the factors which are social determinants of health, intersectoral factors, health-seeking behaviors, and overall performance of the governance. This all affects on the health outcome. We see the healthcare delivery system of Pakistan. We have public sector as well as we have private sector. In public sector, we have federal government and provisional government. Federal government has one of the Ministry of Defense, which includes the military hospitals and cantonment boards. And there are the other ministries which come under the federal government, includes the research institutes, hospitals, and vertical programs. In case of provisional governments, there is a provisional Department of Health, which includes primary, secondary, and tertiary care. As far as the private sector is concerned, there are the major hospitals, individual participating GPs, Hakims, homeopathics, NGOs, philanthropic organizations, and traditional healers. In Pakistan, many agencies are delivering health. Agencies that finance and provide services for defined population and have mutually exclusive governance and financing arrangements are referred as vertical systems. Other are horizontal and mixed systems. 3 vertical systems including Armed Force Health System, Fauji Foundation System, and Employees Social Security Institute SC. These 3 systems have distinct clientele, financing, and service delivery and governance arrangements. 2 horizontal systems include Pakistan Autonomous Quasi-State Organizations, Pakistan's corporate/commercial entities. These two systems finance health either by pooling for risk through insurance or by reimbursing providers for service rendered. These three vertical and two horizontal health systems almost cover 26.01 million individuals or 16.59% of Pakistan's population for healthcare cost. Third is mixed health systems. Roles are played by public and private providers. This system provides 15.22 million employees of the government and number of judiciary and legislature. It covers 41.73 million or 26.62% of country's population. Remaining 73.3%, which is a huge chunk of population, is not fully covered for health and seeks care by making out-of-pocket expenditures in mixed health system. Now, we see this picture is Pakistan's health system. This green color is mixed system. This dashed green, dark green is horizontal system. And this light green is vertical system. As I have told, we have three vertical systems which have their own governance and generate their own finances, which is Armed Force System, 4.01%, then Fauji Foundation, 5.8%, and SC, 4.39%. So they have their own revenues, profit by commercial activities, predetermined philanthropy. Then the autonomous agencies, this is the horizontal program, and private employers, the horizontal programs. Employers' contribution. And this is the mixed health system, which includes three-tiered public system and market system. It has the revenues, out-of-pocket payments, development assistance, and philanthropy. So again, is the Pakistan health system population received coverage by the health percentage. You can see the armed force, publicly managed private means, then it is government, then the members of judiciary and legislature, safety nets, and corporate sector. And this is the huge chunk, 73.8, which is out of the pocket payments. Again, if we see the access of healthcare services is mixed health system. So we have this one, a large portion, which is private health providers. Then this one is public hospitals. Then this black one is publicly primary healthcare system or retailers in private sector. And the last one is the traditional private sector health providers. As you can see, the overall performance like this. Then in the rural, it is private hospitals, then the public hospitals, then this area, and then the traditional health. And the urban areas, almost more than this is covered by the private, and then again the government and the remaining ones. What is mixed health systems? It is defined as health system in which out-of-pocket payments and market provision of services predominate as means of financing and providing services, respectively, in an environment where publicly financed government health deliveries coexists with privately financed market delivery. First of all, the public system in it. It has a strong post-colonial imprint with a national health services model operating albeit with several gaps. Revenues and development assistance finance the public system or the state's health infrastructure. It comprises of national public health programs. These are the set of disease-specific, federally led public health programs, for example, HIV and AIDS, malaria, tuberculosis, and hepatitis programs. 3 tiers of services deliveries, which includes primary, secondary, and tertiary. As we can see this pyramid, level 1, level 2, and level 3. Level 1 is the primary care. It's the first level healthcare facilities, including basic health units, rural health units, and dispensaries. Then the level 2, which is secondary care, it includes THQs and DHQs. And the third is tertiary facilities, which includes the teaching hospitals. So again, Pakistan's public healthcare system, primary care, secondary care, and tertiary care. In the primary care, you can say this, it is the lady health workers, family welfare clinics, dispensaries, maternal child health centers, basic health units, and rural health centers. This all comes in the primary care. Then we have referral goes from here to, should go to THQs and DHQs, Tehsil headquarters and district headquarters. And then the hierarchy, tertiary cares, which is teaching hospitals. So basic health units, a medical facility situated in the smallest administrative unit of government, which is a union council, with an average catchment population of 10,000 to 20,000. Rural Health Center, an upgraded primary healthcare facility located in sub-district administrative unit at the junction of 4 or 5 union councils. The population served ranges from 20,000 to 50,000. Then the first level care facilities, FLCFs, comprises of BHUs and RHCs. The maternal and child healthcare center, MCS centers of Department of Health, the family welfare clinics, which is family planning facility of the Ministry of Population Welfare, then the lady health workers, village-based female community health workers, tehsil headquarters, district health secondary care, and then the tertiary care. Then comes a mixed system. Second one is the market system. Characterized by a diverse range of non-state actors, exists along with public system in Pakistan and plays a dominant role in providing healthcare. This system is heterogeneous in terms of qualification of healthcare providers, the system of medicines followed, status of registration of providers, and duration of their practice. In terms of qualification, non-state providers range from doctors possessing medical degrees to formally trained allied health professionals such as nurses, midwives, DIs, TBS, trained birth attendants, lady health workers, lady health visitors, and untrained health providers, including paramedics and laboratory technicians. Faith healers also function within this environment, especially in case of mental illness. Drugstore operators, retailers, and unqualified sellers are also part of informal providers. With respect to medicines followed in this system, main dominance of modern Western allopathic medicine, also traditional medicine, including Tibet, Unani, Ayurveda, homeopathy. 5% of total healthcare services provided by this traditional medicine and are registered by their respective registration agencies. For-profit healthcare sector, a range of private sector healthcare facilities also characterize the market system. For healthcare sector includes ambulatory clinics operated by general practitioners and specialists, maternity homes, private dispensaries, diagnostic facilities, and private hospitals. Generally, these infrastructures is concentrated in major population centers. Non-profit healthcare sectors. It comprises of NGOs, non-government organizations, and charitable and trust-funded organizations. Pakistan's largest and most effectively functioning ambulance networks is owned and operated by charitable trust, which is AIDHI Foundation. NGOs have traditionally played significant role in delivering family planning services in Pakistan, for example, Rahnuma. NGOs also been active recently in areas of HIV and AIDS due to availability of funds. The mixed health system syndrome. Despite of existence of mixed health system, Pakistan is failed to achieve health for all. The failure is due to interplay of triad of determinants, which are inadequate state funding, burgeoning unregulated role of private sector, lack of transparency in governance in mixed health system. This can be more elaborated by this picture. It is a public-private nexus in institutionalizing malpractices in healthcare sector. As you can see, there's preferential treatment in hiring and misappropriation of talent, clouding of business environment and resulting collusion in public procurements, lack of evidence-based decision-making and state capture, and unethical marketing practices. This all leads to absenteeism, shaving of hours, ghost workers in public facilities, because of dual job holding and care providing in the private sector, then the inability to maintain deliberate undermining of public equipments, paucity and poor quality of supplies all occurs in public sector, which leads to low quality of public services. And in private sector, this unethical marketing practices leads to high cost of care. And all these preferential treatments, they all ultimately leads to low quality of public service. And this both public and private weaknesses leads to equity and quality in healthcare delivery undermined. The public market interaction in the mixed health system and its manifestation evidences by compromised quality, and equity in healthcare delivery system has been described as mixed health system syndrome. The public-private mix is, however, not a guarantee of poor performance. Locally relevant public policy choices can be adopted to develop steward mechanism which influence the behavior of private providers. Factors leading to poor health status. Health is an intersectoral responsibility. Different factors are responsible for poor health status of country's population. These include social determinants, poor governance, and low public investment in health sector. Factors in the intersector domain include clean water, solid waste disposal, food security, occupational health and safety, safe working and general environment. Political factors, conflict and disasters, poor performance of the health system. Now moving towards the health system domains, which are information, organization, service delivery, financing, human resource, leadership and governance, medical technologies. All this leads to health system. Now going one by one and discussing one by one. Number one, health governance. The viability and success of reform within any state sector is closely dependent on overall governance, effectiveness, and institutional ability to mainstream change. Reforms of governance is the most difficult state to form because of inextricable relationship of governance with politics. Health governance refers to governance within government agencies at various levels of the government system, including federal, provincial, and local. Set of factors. World Bank scopes governance within policy making and implementation. Domestic health governance principally involves three sets of actors within Pakistan mixed health system. Number one is state actors, number two, health providers, and third is beneficiaries. Number one, state actors. Includes stakeholders in public sector within and outside the health system, includes ministers and secretaries of health, civil and technical bureaucracy, and other staff at federal, provincial, and district level. At institutional level, the Ministry of Health, Provincial Department of Health, EDOs. Political levels includes committees of parliament, and the public actor includes Ministry of Finance, Planning Commission, public procurement agencies, and insurance companies. Health service providers in state and non-state sectors. Beneficiaries can be classified on the basis of income, location, or category of services needed. Health governance can be classified into three domains: setting strategic directions, implementation and oversight, and regulation. Second come the health financing. The mode of health financing is one of the major factors determining both the configuration as well as the performance of the health system. The major disparity in health financing in Pakistan is the predominance of private means of financing, which is out-of-pocket payments as opposed to public means of financing healthcare. Health financing can be categorized into three, which is collection, pooling, and purchasing. Collection. There are 6 modes of collection within the country. 1, public revenues. 2, out-of-pocket payments. Donor contributions. Employers' contribution. Philanthropy. Commercial profits predetermined for social protection. So you can say in this, sources of collection, revenues, federal government, provincial, district bodies, and government safety net. All this leads to the percentage of contributions, 33.32%. And the employers, which includes autonomous body, SC, and private employers, leads to 5.07. Then the donors, commercial, philanthropy is this. The maximum collection is by the out-of-pocket payment, which is 57.33%, and it leads to a total of 100%. Then the pooling. It is a mechanism to ensure that citizens do not have to pay for the bulk of care when they fall ill. This can be done either through insurance or exemptions from payments. It includes number one, health insurance. In Pakistan, it can be described as social health insurance, private health insurance, community health insurance, and takaful, which is the Islamic way of insurance. Then the exemptions. Pakistan existing social protection and safety net arrangements and fund exemptions for poor patients in public hospitals are Zakat and Baitul Mal. Then come the purchasing. When a public or a private entity pays a healthcare provider in exchange for curative or preventive services they render to an individual or population, the entity is seen to be purchasing the services as a third party. The concept of purchasing is interlinked in health system policy. This approach makes sense in mixed health system where non-state entities are the major providers of services. Purchasing can be employed as a tool not only in public-private partnership but also in government to public sector service delivery agency relationship by employing performance-based financing and incentivizing state actors. Third is service delivery, delivery of health services and ensuring citizen satisfaction, equity, and quality is one of the goals of the health system. Attributes of the service delivery include service availability, service quality, service utilization, and outreach coverage. Service delivery challenges in the mixed health system. Pakistan has many islands of excellence and numerous professionals of high repute and integrity. However, insufficiencies and malpractices are widely prevalent and act as a major barrier in improving health services and system. These malpractices include staff absenteeism, dual job holding, theft of supplies, procurement discrepancies, unethical behavior, and indifferent attitude of staff in service delivery and patient care. Now you can see this. This is the whole system: administration, clinical staff, medical, legal, and paramedical support staff. In service and maintenance contracts, collegian in procurements and contracting, medicinal devices and related technologies, collegian in this again. Then the medical equipment and supplies, deliberate undermining the assist private activity and theft of parts. Then the billing system, bribes and commissions, unauthorized payments and for payments for services meant to be provided for free. This occurs at the level of administration. Then the clinical staff, dual job, holding, shaving of hours, absenteeism, use of public leverage for private practice, receiving unethical incentive from pharmaceutical firms and commission-based incentives from diagnostic facilities, then limited adherence to evidence-based guidelines. Then the medical legal, receiving unethical incentives of folk reports. Then the paramedical and support staff, unauthorized payments, payments for commodity services meant to be provided for free in public facilities, impersonating factors and illegal private practices, pilferages for supply chains. This all leads to the malpractices. Fourth is health-related human resource. Individuals are strategic actors within the system who can act individually or collectively to facilitate the process of improving quality and efficiency. Number 8 includes a shortage of health-related human source. Healthcare provided population ratio. Assessment that benchmark international recommendations provide evidence of numerical inadequacies in many categories of health-related human resource in Pakistan. Numerical inadequacies are particularly pronounced in case of dentists, midwives, nurses, laboratory, surgical and anesthesia technologists and assistants, pharmacists, biostatisticians, qualified health management specialists, and environment and public health specialists. Even though the current doctor population rate is 1:1326, is lower than WHO recommended ratio, which is 1 to 1000. Maldistribution and ineffective deployment. Health outcome can be improved if the workforce is effectively deployed, given adequate incentives, and managed efficiently. Foremost is the lack of incentives, which promotes health providers and health administrators to serve in private sector or seek employment overseas where better incentives are offered. Secondly, poor infrastructure of public health facilities contribute to maldistribution as it drives providers away from rural and peri-urban areas to larger towns and big facilities.
Dr. Sadia? We can't hear you.
Okay, ma'am. Can you hear me?
Yes, please. Please continue.
Uh, Ma'am, I'm going.
Please go to the next slide, please.
Yes, ma'am. Sorry. Okay. Health outcomes can, okay. Yes.
We have been through this maldistribution.
So the training and
Please go to
capacity building. Education, training, and capacity building should be the centerpiece of Pakistan's human resource policy. Many issues need to be addressed in the domains of undergraduate education, postgraduate education, in-service training, and continuing medical education. Fifth is medicine and related products. According to WHO, a well-functioning health system should ensure equitable access to essential medicines, products, vaccines, and technologies of assured quality, safety, efficacy, and cost effectiveness, and their scientifically sound and cost-effective use. A number of factors are influencing access include sustainable financing, affordable prices, reliable health and supply systems, and rational selection of use. It can be described by the access, rational drug use, affordable prices, sustainable financing, and reliable health system. Then is the technology and health system. Technology has brought significant value to many health system domains by improving efficiency, controlling costs, reducing human errors, facilitating new services, and improving connectivity. Useful applications of technology in the health sectors include the health information systems, telemedicine, continuing medical education, maintaining national health records, and promotion of transparency. These are the reference of the Choke Prize Reforming Pakistan Mixed Health System by Dr. Sania Nishtar. Recent advances. It is one of the article by the World Health Organization. Okay. In which the healthcare delivery system in Pakistan consists of public and private sectors. It includes the state provides health through a three-tiered healthcare delivery system and the range of the public interventions, and they have given the figures. The public health activities have persistently increased in terms of physical infrastructure and workforce. The national health infrastructure comprises of 1,201 hospital, 5,518 basic health units, 683 RHCs, 5,802 dispensaries, 731 maternity and child health centers, 347 TB centers, and the total availability of bed in these health facilities is estimated to 1,23,394. In addition, more than 95,000 lady health workers are providing primary healthcare services to the community through their health houses. Second is one of the articles published in JSP, Pakistan's health system against COVID-19, where do things need? In this, they have told that the framework of analysis was by using the Kilman's health system framework and 6 building blocks of WHO to assess the national response of Pakistan to COVID-19. The framework was organized into 3 tiers. In the first tier, related to the broader policy environment and the laws and guidelines formulated by the federal and provincial governments and the economic, social, cultural, and political ecosystem for combating the virus. In the second tier, the capacity and the performance of the health system of Pakistan was determined according to 6 building blocks of WHO. And then in the third tier, community participation and people's attitudes, perception, and practices in the ongoing war against this invisible enemy was assessed. As you can see in the first tier, social, culture, environment, and political ecosystem. Then the second tier, it was health delivery, workforce, everything was covered in this. And then the community participation will include the wearing of masks, social distancing, and hygiene practices. Now, moving towards the multiple choice questions. First question, health systems are difficult to categorize into various models due to diversity in financing and service delivery arrangement. In mixed health systems, publicly financed government health delivery coexist with privately financed market delivery, and which of the following countries fall in this category? America, Canada, Western Europe,
Pakistan.
yes, Pakistan. Number 2, in Pakistan, many agencies. In Pakistan, many agencies are delivering health through vertical, horizontal, and mixed system. Which of the following is providing horizontal system of health? Armed Force Health System, Fauji Foundation, Employees Social Security Institute, and Pakistan Autonomous Quasi-State Organizations.
Employee Social Security Institute.
No. The above three are providing vertical programs, having their own governance and financing. The last one is one which is providing horizontal program, Pakistan Autonomous Quasi-State Organization. In mixed health system, roles are played by public and private providers. It covers 41.73 million or 26.62% of country's population. Remaining 73.38 of the population is not fully covered by health and seeks care by insurance, out-of-pocket expenditures,
Out-of-pocket.
reimbursements,
D.
zakat.
Out of pocket.
The out-of-pocket
Yes, out of
expenditure.
pocket. Despite of existence of mixed health system, Pakistan has failed to achieve health for all. The failure is to interplay of the following determinants, except inadequate state funding, burgeoning and unregulated role of private sector, lack of transparency in governance, excellence and professionalism, and unethical marketing practices.
Delta.
Delta.
Yes, the D is the correct answer because it is the exception. The viability and success of reform within any state sector is very important for effectiveness and institutional ability to mainstream change. Which of the following is the most difficult state reform because of inextricable relationship with politics? Reforms in finance, human resource, governance, technology, and service delivery. Which of the following?
Service delivery. Reforms in service delivery.
No, the correct answer is reforms of governance. It has a very close relationship with politics and is the most difficult state reform to change. Then the mode of health financing is one of the major factors determining both the configuration as well as performance of the health system. There are different modes of collection within the country. Which of the following has maximum contribution in collection? Public revenues, donor contributions, employers' contribution, philanthropy, out-of-pocket payments.
Out-of-pocket payment.
Out of pocket.
Yes. E is the correct answer. Pooling is a mechanism to ensure that citizens do not have to pay for the bulk of care when they fall ill. This can be done either through insurance or exemption for payments. Which of the following is a form of insurance relevant to Islamic society? Health, social health insurance, zakat, private health insurance, takaful, Baitul Mal. No, the Islamic way of insurance is takaful. D is the correct answer. Education, training, and capacity building should be the centerpiece of Pakistan human resource policy. Which of the following doesn't come in the domains of training and capacity building? Undergraduate education, postgraduate education, policy formulation and implementation, in-service training, continuing medical education.
Policy in formulation and implementation.
Yes, C is the correct answer. It comes under the governance. According to WHO, a well-functioning health system should ensure equitable access to essential medicines, products, vaccines, and technologies of assured quality, safety, efficacy, and cost-effective, and their scientifically sound and cost-effective use. A number of factors are influencing access, include all except sustainable financing, affordable prices, reliable health and system supply, rational selection and use, and incentives.
Incentives.
Yes, E is the correct answer, incentives. Last one, technology has brought significant value to many health system domains by improving efficiency, controlling costs, reducing human errors, facilitating new services, and improving connectivity. During COVID-19 pandemic, which was the most useful application of technology for the general public? Health information system.